Thank you. The Swedish ankle register is a very small, very tiny register compared to those huge knee and hip registers. But nevertheless, it's important, otherwise I wouldn't be here. It's young, so the history is short. We don't know if we have seen any benefits yet, so I can close now, the history and benefit. But I feel quite confident when I presume that most of you don't know very much about total ankle replacement. So I'm going to give a little talk about total ankle replacement and the register. Historically, in the 70s, with the successes of hip and knee replacement, people thought that they could apply the same concept on other joints. So here we have the first generation of ankle prostheses, cemented two-component prostheses, metal on polyethylene. It didn't work. The market was flooded with different designs during the 70s and the early 80s, and everyone was a disaster. Now, nowadays we can fully understand that to cement a component on 3 square centimeters of dense, hard talar bone, it cannot work, and it didn't. For the lower one, we showed from Falun and Malmö that the 10-year probability for talar loosening was, for talar survival was 16%. So nowadays we're talking about the third generation prosthesis, which is uncemented. They are all uncemented. They are 3-component, metal up, metal down, and a mobile polyethylene bearing in between. The contemporary used ankle prostheses are very much look alike. Why an ankle register with such small numbers? First, it's still controversial. Secondly, the number of replacements performed each year is limited. Most people do less than 10, if they should. So I started the register in 1997. We have complete data of all third generation ankle prostheses since 1993. We know everybody that replaces ankles, and if they don't report, we call them, we mail them until they report. So we have 100 or 99.99% reporting success. Primary arthroplasties, of course, and revisions and other secondary interventions. I'll come back to that. Since 2008, we include ankle arthrodesis and rearthrodesis and supramalleolar osteotomies of the tibia. So our hope is that we, for our successors, should have a complete database of the surgical treatment of ankle arthritis. Of course, we use demographic data and surgery-related data. We also use different scores, but not those objective parameters. We have a website where the surgeons can get their report forms. We still report on paper. The register was handled by myself for many years, but since 2005 it's handled by the National Competence Center in Lund, the NKO in Lund, and the paper reports goes to a secretary in Malmö who put them into the database. Here you can also get the questionnaires for the patient and before and in the follow-ups. We have used 4 different scoring systems. The EQ5D and SF36 and the HFQ hindfoot questionnaire. It is a Selenian the Selenians have redone the Oxford 12 to suit the ankle, and it is just now being validated both in Swedish and in English by zillion people. It's almost finished, and it is valid. We have abandoned the FAOS score. Now it's too many questions, too complicated. Today we have 784 primary ankle replacements. The annual number you can see here, top number 762003. But it seems like the annual number, something around 70 prostheses a year in Sweden. The need is probably higher, a little bit higher. We do less than our neighbors. Denmark is doing more as well. Swedish orthopedic surgeons are more prone to fuse the ankle. As in other registers, rheumatoid arthritis are slowing down because of the fantastic medication they get nowadays. It is centralized, which is the red one. No, it's green. Okay. As you can see, there is some centers doing most of the replacements in Sweden. And of course, there shouldn't be things like that. But the Hässleholm case is done by the Malmö guys going up to Hässleholm. Karinska in Solna, I've done some of them. In Sundsvall, I've done most of them in Sundsvall. And those have abandoned the procedure. So it's quite a few hospitals dealing with this procedure. And it's not only a centralization, it's of course also the fact that surgeons interested in this type of replacement, they are more prone to replace than to fuse. There are 4 national registers that have published their results. The Swedish register is so far still the largest. What about seniority? That's the name of the day, isn't it? Many prosthetic surgeons who have tried to replace an ankle, they feel that the ankle replacement is the most tricky and the most demanding one compared to hips, knees, shoulders, and elbows. So nowadays it's more or less only designated foot and ankle surgeons who are dealing with total ankle replacement, because you must have experience to know why, when, and how to do all these other procedures. But if you don't get a well-aligned, stable joint, it will not be any success. That's why you have to have experience. The 6 surgeons in Sweden who have done most ankle replacements, they started with it at quite a high rate. It's not a procedure for registrar level. It's a procedure for experienced people and experience in foot and ankle surgery. For example, we published a small material from Falun and Lund, 93 prostheses. As you can see, there were 36 simultaneous procedures beside the replacement. Then we had 7 revisions, and we had 25 other reoperations, not non-revisional. So it's very much to do when you take an ankle. There's no agreement in the literature about what a revision of the ankle is. I mean, if you've got a stiff ankle and you have to do an Achilles lengthening, is that a revision? Or you have an ankle that's in 1.5 years later, you replace an ankle, the foot is in varus, and you have subtalar arthritis, and you do correct it with subtalar fusion. Is that a revision? So we searched the literature and found very, very many definitions of revisions, and we have proposed, soon coming in foot and ankle surgery, this definition of revision of total ankle replacement. We need a global definition, otherwise we cannot compare survival rates, revision rates from different centers and different designs. We use it in the Swedish ankle register. After some discussion, the UK register is also using that definition. It has been approved by the British National Health Service, and it has now also been approved by the top French guys after a long mail discussion. So it's our hope that this definition will be global. When we look at the Swedish register, you can see the reasons for revisions in early period, mid-period, and later period. Mechanical loosening has deteriorated through the years, as has technical error. Infection is about the same. Pain, about the same. Instability, a higher figure. We don't know why. The most probable reason is that some surgeons are getting more courageous, if we can call that, doing impossible ankles. Another way of looking at it, loosening, lowering, decreasing, and technical error. So we learn. It's an effect of a very, very long learning curve. We took 30, the 3 surgeons in Sweden that are doing most ankle replacement, there are respectively 30 first cases of the STARS prosthesis, respectively, that is 90 prostheses, compared to their later STAR prosthesis, that's 132, and you can see that we can gain from our learning curve and from experience. Also a survival curve in 5-year periods. The green line represents the early outcome, and there was 2 major reasons for that. First of all, everybody started with the STAR prosthesis. The STAR prosthesis, Scandinavian total ankle replacements. The STAR prosthesis was a technical, very difficult, very tricky prosthesis with, let's say, inferior or maybe impossible instrumentation. And furthermore, everybody was early in their learning curve. So everybody did all their early mistakes with an impossible prosthesis. That's why. So nowadays, we will never reach the hip and knee results, of course. The BP type, the red line, look at the red line, it's the BP type visual papas. We have that as a collection name for all contemporary modern designs. At the time, we thought we had too small number for each, so we took them together, and it's now a quite nice figure of 87% survival at 8 years. We think. In the Swedish register, as well as in the knee register, lower age surgery implied an increased risk of revision, but gender and diagnosis didn't. So, Stricter indications, probably very important. Surgical experience, of course, and improved designs, improved instrumentations will improve the results. Thank you.
Thank you very much, Anders. I hope there are some questions, because as you said, most people does not have any large experience. Peter?
Well, in English, yes. I did